Good evening, sir. Sir, I'm Sakardeep from LTMMC. Sir, this is 11 years old boy, first by birth thought of, born of non-consanguineous marriage, Mahar by community, Buddhist by religion, hailing from and resident of Buldhana, Maharashtra, was brought an informing father who is reliable, admitted on 2nd of this month with the complaint of fever for 5 days. So according to the informant, child was having moderate grade fever since the past 4 to 5 days. It was insidious in onset, undocumented, subsided temporarily for few hours with medication, but then recurred back. Child had 3 to 4 fever spikes each day, despite being on medication, but now after admission, the frequency of the fever spikes have come down. Fever is not associated with chills and rigor, cough and cold, loose stool, vomiting, pain abdomen, or any difficulty in swallowing, burning sensation or pain while passing urine, joint pain, headache and convulsion. 2 days prior to admission, child was taken to Bhandup Hospital for the same complaint, where he was given some medication for fever, but the fever did not subside, and also some blood investigation was done, which was suggestive of low hemoglobin, as told to parents, and so referred to this hospital. So the child has significant past history. On inquiry,
What do you make out of this so far? So what history did you get so far, and what can you start thinking about? Okay, so what is the age of the child?
say 11 years.
Okay. Come on, start speaking something on what you can make out from this.
Fever for 5-6 days, but getting better. Whatever treatment given. So fever is getting better. And casually, the doctor found pallor. That's the story. We need to guess what must be the problem.
And also, interfebrile period, the child is that unique.
So active in the
Potential.
interfebrile.
But he mentioned there were no other symptoms. Okay, 7-8 days of fever, no other symptom. Pneumonia, meningitis, all that gone. Okay. But still he is getting better with whatever. What do you make out of all this? Come on, give a thought.
So what could the fever be, and after which fevers do you suddenly notice pallor?
So we see after malaria commonly.
So she also said malaria. So now discuss it further.
So
Points for and points against.
So malaria would have presented with fevers with rigors and chills in an 11-year-old boy. They must have, either they are giving prophylactic paracetamol which might hide this kind of presentation. That could be one differential to keep in mind. And
Fever with rigors is not malaria now, and fever with rigors could be anything. So let's not put that as first possibility. Okay. This child's fever is rhythmic. Every 4-6 hours the fever comes. That seems to be unusual for malaria. Okay. And if that was malaria, the doctor could have noticed even pallor earlier. Okay, somewhere at the end of few days, pallor was noticed. Okay. So first thing, is pallor related to fever or unrelated? For example, if fever is related, is it aplastic anemia, leukemia? What is it? If it's unrelated, then we can think of many things. What do you think? Is fever related to anemia? Yes, doesn't matter. We may be wrong absolutely.
Could be mycoplasma causing.
Okay, so now good thought. So which means you started thinking. that this could be mycoplasma and it has caused a hemolytic anemia. Okay. Now take both the things and think deeper. If the fever was mycoplasma, what else classically would you want along with the fever?
What would be other symptoms of mycoplasma?
Classically, there are exceptions, forget. How does mycoplasma infection come classically?
Where is the anatomy?
Walking pneumonia comes as a
Walking pneumonia, but pneumonia, yes, which means what else?
So what symptoms?
cough.
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 Okay.
And pretty severe cough often. It's an airway disease, plus the lung parenchyma disease.
And also interfebrile period child not be comfortable. Pneumonia child, he may have ups and downs, but in between bukhar nahi to khelta hai, should not be maybe on day 1 of not day 3, day 4, day 5. Day 3, day 4, day 5, he is not going to be sick. He is going to be sick when there is no fever.
So what else could be? Good. So one is, could it be hemolytic anemia, mycoplasma? And what does it mean? Autoimmune hemolytic anemia, mycoplasma or whatever. So one thing, okay, good. Anything else? Is it likely aplastic anemia or leukemia?
For aplastic, just fever and no bleeding symptoms. Aplastic anemia usually have bleeding with or without fever. The presentation may be related to something related to bleeding.
And also the child won't be that well, would be sick looking.
Irrespective of whether you saw purpuric spots or what, he would not have been better. Okay. And what you said is right, in addition. But first he would not have been better. So that's out. So now we don't have aplastic anemia, we don't have leukemia, we don't have autoimmune hemolytic anemia possibly, but we'll keep that in mind. Could it be deficiency anemia that was noticed? So probably we come to a conclusion that this anemia must have been there earlier, could not have been made out during high fever, and then when fever disappeared, the doctor noticed pallor. Is it acute anemia or a chronic anemia?
Chronic anemia.
Chronic. Why do you say chronic?
So had it been acute, would have been secondary to some acute bleeding episode. So the presentation would have been different. The child would be sick and symptoms would be present.
So what you want to say is that acute anemia is a sick presentation, whatever, acute aplastic, acute hemolytic. He's sick. He has not been sick. In fact, he got better. So this must be chronic anemia. So we came to conclusion this could be chronic anemia unrelated to fever or maybe related to fever. If it is so, what she said, autoimmune hemolytic. Then ask one more question to rule out autoimmune hemolytic anemia. The autoimmune hemolytic is an acute onset. Okay, but yes. What are the other symptoms?
Jaundice.
Ask whether the mother has noticed mild icterus. She may have not noticed it. Okay, it may be mild enough, but ask that. If she says no jaundice.
And also anything else, icterus would occur if the hemolysis is taking dash, dash, dash. But if the hemolysis is taking intravascular, then
Reddish discoloration of urine.
hemoglobinuria. So ask for both.
Now, if it is an unrelated anemia, would it be a deficiency anemia or a hemolytic anemia? Okay, bone marrow anemias are not so happy and normal looking.
Also
so one
keep
of the
the
two.
age in mind. 11
Age in
years.
mind.
So
While at any age, deficiency anemia can occur, which is a common age for deficiency anemia.
Young.
The earlier age group, like.
Can it be any other so-called hemolytic anemia, which is unlike thalassemia presenting as a chronic anemia? Is there a clue in the history? I mean, not meaning anything about any particular, but is there any anemia which is particular to any community?
G6PD deficiency is taken some
Little loudly,
medication
little
for-
loudly.
That is in Parsis, but here the history is consanguineous, some particular community.
Mahar
history
by
Mahar.
community.
Sickle cell. So sickle cell
Which-
is common.
Sickle cell is
Sickle cell
common.
anemia.
Shingi's.
So
Now,
with that-
can sickle be, it may not have a stormy history. Now, after you have a fever which got better, and then you notice pallor, can you think of something? What was that fever possibly which got better? Okay, anyway, we can go.
So if we say this is a hemolytic anemia and not acute, it's chronic, what more question in the history you want to put up? It's a congenital, hereditary, chronic hemolytic anemia. What point in the history will make you strongly suspect it further? Growth failure. Is he short? Okay. Not necessarily everyone is short, but likely he is short. And the parents may not be short. So again, it's not constitutional or genetic. Okay? So you can go that much saying. Having said chronic hemolytic, why not thalassemia minor? Thalassemia major, probably not. It's 11-year-old, he would have come much earlier. Thalassemia minor would look like deficiency anemia. Do you think this could be thalassemia minor? Give a thought.
Why not? So how does thalassemia minor present clinically? Do they come to the doctor for anemia?
No.
So they don't come to the doctor. No? It's an incidental diagnosis most of the time.
So now in the history you could have asked, how severe was the pallor doctor said? If pallor was mild, moderate, thalassemia minor was still likely, deficiency anemia was still likely. But if they said, no, he was looking very pale, then it is neither deficiency nor thalassemia minor by and large. Now in our country occasionally deficiency could be 2 grams also, that's besides. That is how each question, and how do you get this question in your mind? Only when you think what it could be. Okay, then you ask the next question.
When you have one obvious diagnosis in mind, in your mind you say for a moment, this is not the diagnosis. Obviously, suppose this is anemia due to, no, this is not the diagnosis. Then only you will start thinking of alternative. Otherwise, you will get stuck to the idea that this is the common diagnosis and your thinking will not go beyond.
Now suppose when you ask this parent, they said there was no jaundice. Hemolytic anemia is out. I know only thalassemia major which has no jaundice. Rest all hemolytic anemia should have jaundice, no? Suppose
You
this
agree?
mother is sure, no jaundice. Then are we on a wrong track of chronic hemolytic anemia? So which other chronic hemolytic anemia may not have jaundice other than thalassemia major? And the answer is again sickle. Sickle has a jaundice often because of a hepatopathy. One of the vessels supplying the liver are blocked, and that much liver cells are not working. So if that is large number of liver cells involved, you will have jaundice. So if this is not thalassemia major without jaundice, then it must be sickle without jaundice. And when we say sickle, sickle with something, because the next question is, have you had any acute episodes of sickle? If he says no, then it's sickle with something. Okay, how simple the diagnosis could be at the end of all that, right?
So the child has significant past history. On inquiry, the parents told that when the child was 2 years old, the child had developed insidious onset moderate grade fever for the past 4 to 5 days. Again, undocumented, not subsiding with medication, not associated with chills and rigor or rash. The mother also noticed paleness over the body for 1 week. For this, they have taken the child to a private hospital where some medication for fever was given but did not subside, and then some blood investigation was done suggestive of low HP, and then parents brought the child to this hospital for further treatment. No history of an evening rise of temperature or family history of TB or any contact with a TB patient. No history of passage of worms in the stool or vomitus. No history of joint pain. No history of swelling or pain in the fingers and feet or chest pain, abdominal pain, weight loss, bony pain, gum bleeding, or yellowish discoloration of skin. No history of any unknown drug ingestion. As told by the informant, child was admitted in this hospital in view of low HP. Child was admitted for 7 days, wherein he was transfused with 1 bag of blood, and various tests were done, including testing of parents' blood samples and the younger daughter's blood sample as well. They have been informed that the child is having some blood disorder and that it is a genetic disease, and both the parents are also having the gene but unaffected, but the child has been affected with the disease. However, the younger child is unaffected. Child was also started on some medication which was asked to continue for 5 days in a week, once a day, even after discharge. And another medication was given which was asked to be taken twice a day to be continued. On inquiry, the informant told that the first medication was for the child's condition and the second one was for infections. The child was advised for follow-up every monthly and to
Comments. I'll give you it was a joke, but one person went with his wife to a surgeon and said that my wife has a severe abdominal pain and they have diagnosed as appendicitis. So he said, about 5 years ago I thought I had operated on your wife for appendicitis. He said, but this is my second wife. That's possible, isn't it? So what I mean is, do you get an idea what I'm trying to say? There could be a second disease in another parent. So that tells you this must be a joint disease. Okay, one gene coming from one parent, another gene coming from another parent. Okay, let's see how it goes.
So after the first episode, so they have been advised for follow-up every monthly.
They were told increased paleness, fingers and digits pain, chest pain and red urine.
Any clue here? Why finger and digits pain?
So sir, as we can...
No, I'm asking them.
It's okay, sir. He can also speak.
So sir, as they have been informed that it is a genetic disease and both the parents are unaffected but the child has been affected while the other sibling is not affected. So if we infer it as sickle, then sir, this could be features of crisis, vaso-occlusive crisis. So this can cause pain. So maybe the danger signs have been explained to the parent so that they report back.
Yeah, go ahead.
So sir, this was the first episode. So sir, again, so the first episode was sir at the age of 2 years. So again at the age of 7 years, the child was admitted because of moderate grade fever and paleness noticed for 2 days. And this time the child had numbness of the foot since 1 day. Parents were told that the child had low HB, 2 gram per cent, they could mention the value as well, and no other associated complaints were there with the fever. Child was admitted, received blood transfusion, and as far according to the informant was fine thereafter. Child was discharged after 3 to 4 days. Parents were also advised to check the length of one left-sided organ in the abdomen at home. They were checking it as well, and to bring back the child if there is any increase in the length of organ. After this, they lost to follow up till this time. So they
I think again, this child has received blood transfusion 2-3 times. Sickle don't need blood transfusion, and certainly not 2-3 times. So again, we are going wrong somewhere. It looks like a transfusion-dependent hemolytic anemia. Sickle is
By
not.
now you have all the clues to join the story. What do you think? What is the answer to sir's question that why should a sickle need so many transfusions?
There is a concurrent disease which is contributing to this picture. Most likely some thalassemia trait which is manifesting along with sickle cell.
First thing is that he is not dependent. He has had one transfusion earlier at 2 years, another at 7 years. Where is he dependent? Okay. He has a long interval between 2 transfusions. So it's not blood transfusion dependent. He could have been added on to deficiency anemia. Could he have had a crisis? Hemolytic crisis, aplastic crisis. Okay. Or a sequestration in the spleen. Do you think that could have happened and that's why they had to transfuse him? What is your guesswork on so far what we have heard?
Such episodes would have taken a stormy course.
Okay, we have not heard any stormy course at all, no? So it must be something that's happening slowly over years. Could be part of sickle itself or maybe part of deficiency added, whatever, right? And I think to advise them to look for increasing length of left hypochondrial swelling looks a little unusual. Not easy for parents to note that. For a doctor, yes. Okay, so possibly that's, but yes, if the parents are so much well informed and all, they could also be. But possibly what you could have said is, we have told the parent that if it suddenly increases in size, then come back to us. Okay, that may be acceptable, but not slowly increase. And that puts up to another question, do sickle cell have a splenic enlargement? No? Or yes? Or yes, no?
Yes, no. So till the age of 5 years. So till the age of 5 years, they can have splenomegaly. So more like, sir, if there is any sequestration crisis, the sickle-shaped RBCs will be trapped in the splenic sinusoids, and this can produce splenomegaly. But then, eventually, with repeated infarcts in the spleen, autosplenectomy can occur later on, and splenomegaly may not be.
Why are the spleens shrinking in sickle? And that's why you said they are small.
So he said repeated infarcts.
Yeah, so your answer is not everybody gets an infarct. And I think in Maharashtra, especially in Nagpur area, it's not rare to see a large spleen in a sickle cell disease. Okay, so we should not bank on that as a small spleen is sickle. No, even a large spleen is sickle, right?
So in the antenatal history, nothing as such significant. No history of any blood transfusion in the mother during antenatal period. Child is full-term, delivered by vaginal delivery, 3.5 kg carried immediately after birth. No history of an ICU stay, discharged on day of life 2. Child is immunized till date as per national immunization schedule. Child has achieved all the age-appropriate milestones with average scholastic performance. So child is non-vegetarian by diet, takes diet containing food items from all the food groups. So in the family history, no history of any blood disorder in other family members. So sir, I have drawn this like depending upon the history that they have told ki, both the parents have gene but unaffected. However, the child is affected but the younger sibling is not affected. So since both the parents are unaffected, so they could be trait or carrier state. But since this child is affected, so this is the affected one, however the younger child is unaffected. So it could be beta plus or HBC along with HBS. So according to a modified Kupuswamy, the child is belongs to upper lower socioeconomic class. So my impression is 11 years old male child, birth and developmentally normal, presented with fever, known case of some blood disorder, probably a case of hemoglobinopathy, could be sickle cell anemia. So on examination, child was lying comfortably on bed with IV in situ in the left hand, afebrile, heart rate 94 per minute regular, RR was 24 per minute regular, peripheral pulses were well felt, normal in volume, no radial or radiofemoral delay, central pulses well felt, BP was 108 by 70 in the right upper arm in supine position. So anthropometry wise child is normal. So head to toe examination, hairs normal, skull size and shape normal, no hemolytic faces basically, no obvious facial deformism. Pallor is present but no icterus, cyanosis, clubbing, colonychia. Upper limbs, lower limbs are normal, spine is normal. In the systemic examination, so a gastrointestinal system, shape of the abdomen is normal, all the quadrants move with respiration, no visible lumps, scar mark, visible peristalsis, bleeding spot or dilated veins. Position of umbilicus is central inverted, hernial sites are intact. In superficial palpation, no superficial tenderness or rise of temperature. Deep palpation, spleen is 5 cm, although it is regressed now, below left subcostal margin, along the axis, smooth surface, firm in consistency, splenic notch felt. So liver is not palpable. Percussion notes are, as such it is tympanitic, but a dull note is present in the left hypochondrium. Auscultations, bowel sounds are present. So other systems, nothing significant, all within normal limit. So my impression is 11 years old male child, birth and developmentally normal, immunized till date, admitted with the complaint of fever, and the known case of some hematological disorder, probably a case of sickle cell anemia.
So how do we interpret? No hemolytic faces, just a spleen. How can we call a hemolytic anemia? Firstly, was the growth affected? So what does it tell you? In thalassemia, growth is affected. In this child, growth is not affected. Why not? He is also hemolytic. He is also hemolytic.
It's not a chronic.
Chronic
it's
persistent
episodic.
pallor which will affect growth. These are episodic anemias, and therefore his growth may not be affected. Give you an example. For example, people with asthma, they have significant asthma, but if they have episodic asthmas, then their growth may not be affected as against a chronic lung disease. So that's why the growth may not be affected. This child's growth is not affected. Okay, anything? So significant findings are pallor, splenomegaly, no hepatomegaly, liver is not palpable, and other things are normal. So how will you discuss this? Pallor, splenomegaly, without hemolytic faces.
So sir, episodic hemolysis, that too extravascular.
So one is, it could be a hemolytic anemia where the hemolytic episodes may be not continuous and progressive but are episodic. But can it be not a hemolytic anemia? This child has pallor and splenomegaly. Can it be malaria? He's coming from wherever he is. Okay, we'll keep that in mind. Though significant pallor at the time of presentation may not be there, but there would be some history of recurrent fever in a child of malaria, or for that matter Kala-Azar also. So this particular child has no history of recurrent fever. Some fever at 2 years, some fever at 5 years and 10 years. Malaria would come as fever for 6-7 days, very high, then there were episodes of normal, again fever very high. So that would be, so but we'll keep malaria at the back of my mind. Can it be a non-hematological disease?
Every child who is pale may not have hematological disease. Liver is soft, just palpable, and a spleen is big.
So
Can this be extrahepatic portal hypertension?
Today he has not vomited, tomorrow he'll go home and vomit blood.
Think and answer.
You have seen.
Obviously,
quite a
you
few
can't swear and
extrahepatic.
say that it's not.
Yeah.
But then what are the points against?
So hepatomegaly would have been more than splenomegaly.
But extrahepatic, no.
Excellent.
So in fact, presence of a normal liver favors extrahepatic. You have seen some extrahepatic, 2, 3, what were their presentations? And at what age?
Younger.
Varicose bleeding, dilated veins.
Hematemesis.
Yeah. What were their ages? 11 years or 3 years, 4 years, 5, 6 years?
Younger.
Younger
age group.
presentation. So this is uncommon. I will entertain hematological and hepatic disease not related to, or it could be a infectious disease. So if we keep all those causes of splenomegaly, very huge spleen, may not be very pale, can it be CML? So think of all that so that in another case you will make a diagnosis.
So in both these,
Yeah, consistency, Dr. Key, consistency of spleen also matters.
Yeah.
Long-standing splenomegaly, then if it is fibrotic spleen, it's usually formed. But usually such a big spleen is likely to be formed. You had a soft spleen of enteric fever, just palpable, soft spleen, easily missable unless you go in right lateral position, be careful to palpate. But such a big spleen is not likely to be soft.
I think malaria, pre-sinusoidal portal hypertension, hemolytic anemia. What is the biggest difference? What is the presenting symptom? In malaria, fever is the presenting symptom. In a pre-sinusoidal portal hypertension, abdominal lump is the presenting symptom. And in a hemolytic anemia, the pallor is the presenting symptom. If you look at what is presenting symptom, you can take it away. But I'll give you one more diagnosis. And he's here, so we make best use of him. Okay. I think it's a Gaucher's disease, storage. And storage can have anemia also. Because storage is getting everywhere. So now debate that it's not a Gaucher's disease.
so one is the age of presentation, and the child would not have been growing well all these years.
So also bony pain, etc. will be more in Gaucher.
Does a Gaucher's develop anemia? What is the sequence of events? Hemolytic anemia present with pallor. Malaria present with fever may develop anemia. Okay, extrahepatic portal hypertension present with a lump may have hematemesis and anemia. Gaucher's comes with splenomegaly. At what stage in the progression he develops anemia? And why should he develop anemia?
That's because of marrow infiltration, he is developing anemia.
In progressive stage, marrow infiltration.
And usually huge splenomegaly is seen at a younger age, very young, 2 years, 3 years.
So we have the
infantile years, but at any age. And the spleen could be the only symptom to begin with.
And huge spleen.
Yeah, but I recall if somebody comes with just a 2-finger spleen and otherwise healthy, you have to keep in mind storage coming up as well. Okay, because it will go on increasing in size, and if you rule out the 3 causes that we are talking about, think about even doing a test for storage. Okay.
Because what is big today was small some time back. It didn't become huge today. So you may happen to see the child when the spleen was small. You will see after 2 years, then only you will diagnose Gaucher's because big spleen is not necessary.
And if you see a patient with just 2-finger spleen, he goes to hematologist, he has a complete hematological screen. If he goes to a hepatologist, he looks at the liver. Okay, so if he goes to a metabolic problem, he looks at. So everyone looks at from his angle, and we need to see what is the progression, presentation, etc. Right? Come.
येत आहे की हां पुढच्या वेळेला विसरायला होत नाही. मला 10 कारणं माहिती.
So somebody just start talking about what you observe from a distance. Okay. He is a patient, that's it. Okay. Who will start talking, whatever you see.
Sir, he looks.
Yes. Yes, sir.
Shall one of you or two of you come to examine him?
Somebody come here and start inspection of the abdomen.
Come.
Come. Anyone?
Very good, come. Come.
He's having predominantly abdominal breathing. All the 9 quadrants move with the respiration, no scars or. So at this stage, which kind of breathing do you expect? We would expect a thoraco-abdominal.
That's not audible. Whatever you speak.
So at this age, which breathing you would expect? At this age is 11 years. Yeah.
At this age, we expect a thoraco-abdominal type of breathing. On inspection,
Any fullness anywhere? What should you take position when you're looking at fullness of the child? It should be this way or it should be some other way?
from the cranial or caudal
so
end.
that at least you can see both quadrant, na? Correct? So now if you can say from the head end, can you see fullness on any other quadrant which were not seen if you're standing on the tangentially?
Do you think there is any fullness there? Or that's because we know something?
Actually, when you call abdomen distended on inspection, many of us have a large abdomen. We call it distended abdomen? No. So what is distended abdomen for a physician as a part of inspection? You be at the foot end, be at the same level, and if the abdomen is looking beyond the chest, then it's called abdominal distension. Okay, otherwise the fat, etc., several. So those who have a large abdominal fat, when they lie down, it is below the chest level. That is what it is. So obviously, maybe a left hypochondrium is looking a little more prominent, but what is striking at you is that the umbilicus has been shifted downwards. And the upper part of the abdomen looks almost double the size of the lower part, which means something is occupying, and on the left side. So it has to be a spleen. And possibly there is no liver, because there is no other right-sided, right? Fine. And of course there is no ascites, there is no flank fullness, etc. There are no veins. So you know that on inspection you could have picked up a spleen. Now just palpate and give your palpation findings. Now as a routine, do that.
And spleen is palpable up to above the level of umbilicus. It's palpable.
May I try?
Yes.
Any bladder enlargement?
बेटा लंबी सांस ले ले, लेना छोड़ना.
So whenever you say spleen is palpable, you have to describe it a little more. So what all will you add to your description? You said above the level of umbilicus. What else?
So the consistency was firm.
Not that may matter here, but here the field is 1 centimeter. Now what you do is put your hand like that. बेटा लंबी सांस ले ले और लंबी. You can easily feel more firm. It may not, yeah, firm liver here. And even if you put your hand here and ask him to do, it's there. As you come here, it is not so much. Left lobe is not enlarged. So this is the technique of palpation. If you just palpate without asking the patient to take a breath, you may not be very successful. You put your hand, go down, lambi saans le le. Out, lambi, here I feel the spleen. You can try later on. So, liver, sorry. Here also, lambi saans, shabash, bahar. Phir se. Now in this spleen you can, you can feel spleen anyway, but you want not to miss a just palpable spleen.
Yes.
Then if you poke anyway inside, you are not going to get a spleen. Unless the patient takes a deep inspiration, the diaphragm descends and the spleen touches your hand. Spleen is a very shy organ. Okay, if you don't palpate, then it will run away. If you go there and wait, like you wait for XYZ, then she will come, touch your hand, shake hands with you and go back. So go down, lambi saans. Here of course it's too big.
Is it
and
painful?
don't forget to palpate other parts of abdomen, including the genitals.
Is it painful spleen on palpation?
No tenderness noticed, sir.
Okay. Any conditions where it is painful in splenomegaly? Splenic abscess. Okay. That is again complication of sometimes sickle. Any other acute condition? Sir is always taught na. Acute splenomegaly painful, large in size. But these are rare conditions, na? Common. Which one sir has always told you? Acute large splenomegaly that disappears also, called yo-yo spleen, or sarcoidosis again rare. Common. Sir always tell na, if you get large spleen today, after 7 days it disappears. Painful, tender, multisystemic disorder, enteric fever. Okay. Any viral infections which can cause splenomegaly, lymphadenopathy, acute anemia, infectious meningitis. So painful also.
And of course, when you make him sit up, just have a look at his back also.
Spine deformities. Okay.
I think whenever you see a very large spleen, go from right iliac fossa
all the
diagonally.
Cross.
Because that's the way the spleen is going to enlarge. Okay. So take a note of all that. Right?
So briefly, I'll take to the Courson ward. So sir, as he came, we did one CBC for him. So basically, sir, he's a known case. So, but he's since he has lost to follow-up, so some of his reports are pending. They have not brought all the reports with them. So sir, on presentation, this time HP is 5.1, TLC is 2,900, platelet is 1,42,000. Indices are MCV is low 74.9, MCH 24.2, MCHC 32.4. Retic is 0.45. So on this, we have transfused the patient with 5 cc per kg.
Okay, 1 minute. Sir, we said that we know this case, but on its own merit, can you interpret this CBC?
Especially in the light of last time's lecture.
You're getting what I'm saying? On its own merit, try to interpret this CBC.
So bicytopenia is there.
Okay. By or pan?
Pan.
Okay. So pancytopenia.
Penia is there.
Then what else?
Retic count is less. Borderline.
So do you think this is aplastic anemia on this CBC?
Could be pancytopenia.
Could be, nahi, think and tell. I'm trying to ask you something more, something deeper.
In aplastic, which cell line affected first?
Platelets.
And what about this? Like you have seen 3 CBC parameters, and which is a parameter which you think is most affected? All of them?
RBC.
RBC. Okay.
Do you think platelets are low?
Not.
2.4 is okay.
Huh.
So you have a bicytopenia. Okay, which means HLH is a possibility. Now who will talk about HLH? Bicytopenia. Okay, comes to a hematologist, and there is a splenomegaly. Okay, there is anemia. Yeah, this is HLH.
HLH would be a sick-looking child, whether this child is not sick.
And between these conditions, so what would you say is MCV? Is he normochromic or hypochromic? Are microcytic or normocytic, and normochromic or hypochromic?
So MCV is less, though, so it happens to be macrocytic. MCH is also on the lower side, hypochromic.
So now tell me, in aplastic anemia, what kind of picture do you
Usually normocytic,
get?
normochromic.
So say that, no, that is what I wanted you to pick up. That on the merit of this CBC alone also, because it is microcytic hypochromic, it is less likely to be aplasia. That is what we wanted you to pick up, right? Okay.
So we have transfused him.
Also, I thought for a hemoglobin of 5.1, the MC was 74.9 is relatively too good. Isn't that so? I would have expected if it was deficiency, microcytes. But there is always one thing to be remembered. When you have an MCV, then the MCV could be normal if there are microcytes and there are macrocytes to compensate for that. So you may have a normal MCV, but yet it could be a deficiency anemia. So after seeing MCV, where do you see next? RDW. If that is why you know that there are micro and macro, and therefore your MCV may appear to be normal, but while it is not normal.
So we have transfused him by 5 cc per kg on this HP, but the rise was 5.7. Counts have improved. So again we have transfused him with 5 cc, and the last HP is 7.8, and counts are on the recovery trend, 3900. So we did one DCT and ICT for him as well, because the rise in HP was less. So DCT and ICT were both negative, and this is just a liver panel. So bilirubin is normal, SGOT, SGPT are within normal limit. Total protein albumin as well. So since he presented with fever, we did the fever workup. Blood culture showed no growth. Malaria, lepto, dengue came to be negative. We did annual ophthalmic examination. So this so no changes of retinitis or retinal hemorrhages. So sir, his hydroxyurea, he was on 2 medications. He was on hydroxyurea, and they have started tablet penicillin for him in view of infections. So hydroxyurea was withheld, and we started him on cefotaxime. So we thought of starting him on ceftriaxone, but we found ceftriaxone causes immune hemolytic anemia more in this patient. So we started him on cefotaxime. Yeah, and so now we are again planning to restart hydroxyurea.
You have electrophoresis report?
So no, actually it was done, but sir, actually they have kept it at home, and they were lost to follow-up basically. So that's why it was done.
What do you expect on electrophoresis?
Sir, HBS will be there.
How much? How high?
Sir, since it's more or less not symptomatic, so it could be 30 to less than 60%.
What are the other parts of hemoglobin?
So HBS will be there.
HbF? You get increased HbF in a sickle?
No.
So when will you get F?
And there is
If it's a
So in case of thalassemia,
thalassemia.
So if it's a combination, sickle thal, then you will get F as well as S.
Yes.
Right?
In fact, SBF is seen in any condition where the bone marrow is stimulated. But of course, a small increase. Okay. Can you have a moderate or high HbF but no anemia or symptomatic? But HbF is 30, 40%, 50%.
What is that called?
HbF.
Hereditary persistence.
Hereditary persistence of hemoglobin or symptomatic sign, right?
This child's sickling was done, sickling test, and it was negative. Then it went to another lab, there it was positive.
So any false, any
What
reasons
test do you
for
do
negative
for-
sickling test?
When it is false
Technical
negative.
reasons.
What reagent do you use?
2% sodium metabisulfite.
Yeah. So if your sodium metabisulfite is not
Freshly.
fresh, then you will get a false negative test. So make sure that you prepare the solution fresh before you test for sickling.
Why did this child not present early in life?
So,
After all, it's a congenital problem, no?
so it doesn't present in the first 6 months because HbF prevents sickling. So within the first 6 months, we don't get sickle being presented to us.
What about thalassemia major? How early can it present?
During the transition period, whenever there is transition from fetal to adult, by 6 to 9 months, then we can have thal cases being presented to us.
So generally the hemoglobinopathies, even severe, present when a normal HbF starts going down, which is 6 to 8 weeks or 10 weeks. And that is the time that the thing, which hemolytic, genetically determined hemolytic anemias may present at birth. At birth. Thalassemia does not. Spherocytosis.
Can spherocytosis present at birth?
So hemolytic anemias or hemolysis are of 3 types for a clinician. Okay, one is hemoglobinopathies, which will not come at birth. It will come at 2-3 months and thereafter any time. The second is a membranopathy. And the third is enzymopathy. What is membranopathy? Spherocytosis, elliptocytosis. And what is enzymopathy? Hemolytic
T6PD, pyruvate kinase.
Pyruvate kinase. Those with membranopathies and enzymopathies may appear at birth also. Okay, because there is nothing to relate with HbF or other abnormal hemoglobin. So hemoglobinopathies may come up a little later, but the other types of hereditary, that's how G6PD comes at birth.
Yeah.
It almost crosses over the physiological jaundice, etc. So spherocytosis is known to come even at birth, and occasionally even a fetus. Okay. So if hemolytic anemia presents at birth, you know it is not hemoglobinopathy, and your probably focus is on membranopathy or the enzymopathy, right?
Another precaution, this child has G6PD deficiency and he has presented to me severe anemia, and I am going to do some transfusion, exchange transfusion. But I did a test for G6PD and it was normal. Then somebody said, did you do it on cord blood? I said, I didn't do it on cord blood, but I am doing it now, no? And it's negative.
Where is this enzyme normally present? In RBCs. And in severe anemia, what has happened to RBCs?
They are all lysed.
Lysed.
So whatever little RBCs are there who are surviving have a normal G6PD. Those who had deficiency are already gone. So you are getting a false. So that's why you do it on cord blood. where all those which are deficient and non-deficient RBCs are there, so your test will be positive.
How much ml vitamin K should be newborn? What is the current available preparation? After birth, we give vitamin K, na? So how much ml you give? 1 ml? 0.1, 1 ml. Just check it, because a lot of mistakes, there is to be initially 1 ml, 1 milligram. Now we have 1 ml, 10 milligrams. So suppose you give 1 ml, then suddenly G6PD, or even in conditions, it will aggravate hemolysis. So always important to remember.
And we don't give the synthetic variety of vitamin K. Now, of course, it's not available. At our time, Syn-K, it was available, and that can itself produce hemolysis. So we want a natural at that time it was capillin, and 1 ml, 1 milligram, but now we have 1 ml, 10 milligrams. So you should be careful in giving that.
Why are you giving this kind of treatment to this cell? Hydroxyurea. What does hydroxyurea do to sickle cell?
So it increases the fetal hemoglobin and thus prevents further episode of sickling.
And the point there to remember is, in Indian haploid situation of sickle, HbF is often high. Unlike when HbF is low, hydroxyurea will induce HbF and will be beneficial. But a typical Indian haploid situation, HbF is often high. So to that extent, the drug may have its own limitation, and that is just a small additional factor to prevent some crisis, but it does not mean that the crisis is avoided, right? Fine.
Thank
Good.
you, sir.
I think today we have Dr. Murli Mahajan. He is a geneticist, and being a geneticist, he is also a very highly qualified metabolic specialist. Okay, so he combines both the kind of things, and we thought we could listen to him on these two aspects. Okay.
Academically interested, and after being so much away for so many years, 8-10 वर्ष केएमला काढलेत ना.
Sir, clinical genetics.
Just a slide.
So
You may have to adjust the length.
yes, sir, I'll adjust. It is nostalgic because today, when I was sir student as a registrar, we used to do the same thing what you are doing today. One case presentation, and then we used to have 20 minutes of discussion. I've been almost 25 years down the line before I was sir student. So any topic we used to have, even thyroid, CT scan, how to read X-ray, IEM, metabolic. And to be honest with you, our journey with this metabolic disorder started. It started after getting through various tests, and today I will not complicate any of these things. In just 20 minutes, that is what sir has told me, to give a presentation of how do we approach.
But you can be longer because we have finished the first case earlier.
But question answers from there. Yeah. Like you have any questions like what is genome, what is exome, what is clinical exome. Like these are the common terminologies which are always day to day in us. What is microarray, what is Sanger sequencing, what is this thing. That I have not taken the slide because it is too much complicated. So today what I am going to talk about is that only 5 basic tests. Where do we interpret them? Like VBG, sugar, lactate pyruvate, ketones and ammonia. These are called as basically screening test, correct? We call them screening tests because it doesn't give any diagnosis, but lead our front ends to our environment of metabolism. And next, how do we clarify the terminology like GCMS and TMS? I think most of you have been having good experience about GCMS, TMS. When we were postgraduate, there was not further experience about this thing because there was not too many advances in the field of genetics. But today, these tests are available easily. And you know that even molecular tests are available at very cheaper cost. Today, we'll start with this presentation that in a busy OPD, how do you pick up a genetic case? Which test you should do right in the front of him to diagnose screening test, and how do we approach these cases? Fine. So you always get very interesting advertisement like secret of energy, growth, booster medicines, good powders and everything. So like all cricketers will say that boost is the secret of energy. But of course we know that we can't take boost entire day, and that should not be the secret of energy. So what could be the secret of energy of Virat Kohli? Anything. This is simple. Basically, these are all very basic, simple questions and absolutely simple presentation. What could be the secret of energy?
Anushka.
Anushka, fine. Fine. Oh yes. What about Ramdev Babaji? Secret of their energy. Since you have seen, if you see in television, in the month of December, you are doing yoga at home with thermal sweater at home. But Babaji is doing yoga in Haridwar at 2 or 1 degree temperature without, just with basic langot and his basic attire. So you would think, what could be the secret of energy of these people? And most importantly, again I'll say, when I was a student of Dr. Ambedkar, we used to always yawn, be very slow, sluggish and round, sloppy, but I had never seen sir yawning even till late. But he never yawned, he's always fresh. We used to be slow, sluggish, that whenever sir used to come down, tab tak we were very tired. We were always yawning, very feeling, chronic fatigue syndrome. Common, na? All of us are always chronically fatigued, very sluggish, very slow, not very optimistic, little dull most of the time. As the evening passes, you are more dull. In the morning, we are fine. What is the reason for that? You are very happy in the morning, usually in the evening it is dull. Any common basic physiological principle that you are so active in the morning, you feel very dull in the evening. What is there in the morning which is not there in the evening? Hormones, fine. Okay. Anything else, natural remedy which will keep you happy in the morning? Surya Namaskar, sun lord. Na? So again I will tell you what is the interesting role of sun in your day-to-day well-being and how the metabolic disorders are also prevented by sun. So again we know that why Baba doesn't feel cold in the winter when he's doing yoga at 2 degree temperature. There must be something extra in his body. All of us are born with same DNA, correct? God has not differentiated. All your DNA is a name. Like sir was telling today that he spoke about epigenetics. All of you are born to be pediatrician. Some of them choose to be pediatric cardiologist, some may be pediatric nephrologist, maybe some rheumatologist, and some prefer to do general pediatric practice. So God has not differentiated in terms of genes. All of you carry the beautiful same pair of genes. But what is important is epigenetics. There are factors which make something beyond than your routine genetics, that is called as epigenetics. So what could be there in these people that they are very strong and fit? Anything, which just guesswork, rough guesswork, that he doesn't feel cold, they are always happy, cheerful, they never yawn, they are always fit. They look very bright and shining most of the time, and we feel very sloppy, very lethargic, always yawning, very sleepy. In the lecture I have seen sir always sitting on the first seat, and always I am sitting on the last chair. In any MP con, pedicon, if you see Dr. Ambedkar is sitting on the first chair, and almost 8 hours he will attend everybody's lecture. And most of the time we are attending only half an hour to 1 hour of lecture, and most of the time outstanding delegates getting into MR stall, tea, coffee. So what is the secret of them being so fit? Any normal physiological substance which is more in them compared to you. So now I'll give an example. We all have abundant amount of yellow fat, correct? What is healthy fat called as? Brown fat? Fine. What is brown? Yellow plus red. Red is what? Mitochondria. So they are born with a beautiful brown fat. So if you see a cricketer, so today Smith is playing in India, WTC, he'll be going to June. To Lords, well, temperature will be 8 to 10 degrees, but they never feel cold because the athletic, gymnastic body, they are built in such a way that they have carried forward from yellow fat to brown fat. And this brown is basically mitochondria. So if you are born with a beautiful mitochondria, you are likely to have a very healthy lifestyle, you are likely to have a better lifespan, better activities, and better outcome. So today, what I'm going to speak is about various mitochondrial basic illnesses which you should know, and how do you analyze your body substances, the metabolism of this product. This is a simple diagram, and with this diagram you will understand all metabolic disorders. So with our today's lunch, you must have eaten all these three components in the diet. Is anybody doesn't eat carbohydrate? Any one of you don't eat carbohydrate? Or all of you consume carbohydrate? Very good. Most of them advise not to consume carbohydrate. Like some gymnastic people will say just take proteins, go for keto diet, take only fat, don't get carbohydrate. But you should ideally take all carbohydrate. So if you see this diagram, we have protein, fat and carbohydrate. So if you see these three substances, all the metabolic disorders are getting around these three substances. So if I see straight away start with glucose, right? The glucose, if you see the diagram, there is, in fact, I'll just show here, correct? So glucose get metabolized to form this pyruvate. You can see the diagram, right? This is pyruvate. And then lactate. Next. So there is a pyruvate and lactate. What is the importance of this? So sir was asking me, how do we approach a lactic acidemia in clinical practice? So glucose, the basic metabolism is pyruvate. And if you see the diagram, if there is oxygen given to pyruvate, it will enter the Krebs cycle. And if there is no oxygen, pyruvate will form lactate. So if you see clinically, if a child is sick, shock, septicemia, respiratory distress, he will show very high lactate level. That is because there is no supply of oxygen. Because of cutoff of oxygen, this pyruvate will form lactate. Again, see the diagram very importantly. This pyruvate is interchangeable. Moment you give oxygen, lactate will again form pyruvate. So no oxygen, pyruvate will get converted to lactate. So lactic acidemia. So if you see lactic acidemia in your clinical practice, what is the first thing you will ask? Whether the child is hypoxemic, is he sick, like septicemia and shock. If these three elements are present, treat them. Moment you treat, the lactate will slowly go down and pyruvate and lactate stabilize. Now I will ask this simple question. If the child is not sick, lactate is still high consistently and persistently, which disorders you will look at? Like we have heard about MELAS, MRF. So these are what disorders? Excellent. So if I see pyruvate lactic acidemia without hypoxemia, septicemia, shock, then you are looking at mitochondrial disorders. So just by identifying pyruvate and lactate ratio, you can diagnose mitochondrial disorder. And in this diagram, if you see all the other metabolism pathways are fine. So child will not have ketosis or hyperammonemia or any other metabolic pathway. Again, to simplify these three pathways, later on I will classify them into various patterns. Second is ammonia. Ammonia metabolism disorder. We know that ammonia is a byproduct of protein metabolism by GI bacteria. Gut bacteria metabolize proteins to release ammonia. It goes to liver to form urea and then get excreted. Suppose there is a problem in urea cycle or liver problem, what will happen? Ammonia will raised. So ammonia increased will point to which disorder now? Protein metabolism disorder. Correct? Because these bacteria were they were acting on the protein to release ammonia, and which was not metabolized by the liver. So in short, if I say a lactate which is increased when the child is not sick, stable, you are looking at mitochondrial disorder. If you say very high ammonia, again protein metabolism, you are looking at amino acid disorders. Correct? Now let us see the next part, fatty acids. Which are the product of fatty acid? Ketone bodies. Right? So again I'll simplify this thing. One is idli, second is mendu vada, third one is dosa. So if you see glucose metabolism disorder, look for lactate pyruvate. If you look at amino acid disorder, look for ammonia. And if you look at fatty acid disorder, you look for ketone bodies. Now the next thing is organic acidemias. Again simple. Organic acidemia is what organic acidemia? It is like pushpa dosa. Have you eaten pushpa dosa? After the movie Pushpa, anyone tried pushpa dosa? Yes. What is there in the pushpa dosa? Lot of elements, correct? So dosa with Mysore chutney, paneer, capsicum of 2 or 3 different types, butter, and lot of things, ingredient. So if tomorrow you get a child with ammonia raised, ketone bodies raised, hypoglycemia, lactic acidosis, you know that it is coming from a organic acidemia. So organic acidemia, just remember it as a pushpa dosa. It is multiple across all parameters which are affected. And what is organic acids basically? Remember that organic acids are by mnemonic C, vomit. C, vomit, because most of the metabolic disorders will present with vomiting. C is for cholesterol, V stands for valine, O stands for odd chain fatty acid, M stands for methionine, isoleucine and threonine. So if this see the mnemonic, there is a fatty acid, there is amino acid, and there is little bit of carbohydrate. So if you see a metabolic disorder in our OPD practice, which has all elements, lactate increase, ammonia increase, metabolic acidosis, and all these things, it is organic acidemia. If you see simple lactic acid increased, mitochondrial disorder. So if it's just 5 minutes of your time, you have diagnosed such a rare conditions. So easy. So I think it would be easy. It is much easier to diagnose this condition than upper and lower respiratory infection, I would say. Correct? It will require auscultation, a clinical skill, and of course you require expertise like sir to pick up so many respiratory disorder. But to diagnose metabolic disorder, you hardly require anything. Simple, just learn this diagram and you are master in metabolic disorders. What I'm telling, why I'm telling again and again, because if as a pediatrician, I pick the metabolic disorder before it becomes brain dead, you can give them quality of life. Moment you know, propionic acidemia, methonic acidemia, organic acidemia, they become brain dead and they become neurometabolic in origin and they refer to neurologist, we know the outcome is very poor. They won't survive for long, the morbidity is more, mortality is high, the cost of medication high, the outcome is very poor. So as a pediatrician, it is our sincere responsibility just to remember only these pathways, this basic test, and completely diagnose IM before they present to neurologist. Any question in this? Fine. I will tell you how to collect lactate pyruvate, what are the ratios of lactate pyruvate, what is normal ammonia, abnormal ammonia, ketone bodies, that I will just cover in few more slides. Fine. This is a classical diagram of old lady who is holding her child. If you see the child, obviously the feature is that the child looks very sluggish, slight ptosis there, looking little hypotonic, little lethargic. So you have a multisystemic disorder. So which is a likely condition? Which metabolic disorder will affect all of them? Like today you presented one case which just affected spleening. So there is like multisystem is viral, as sir used to always say, viral is multisystemic. So which is the other body part which is organ which is there in all cells of the body? Excellent. Trillion cells of the body, all mitochondria. Which has a body part which has maximum number of mitochondria? Brain. Excellent. Cardiac, there are huge number of mitochondria which are small and compact because the heart is constantly pumping for entire lifespan of the person. Liver, later on, then skeletal muscle. So if you see a disease which has affected brain, cardiac tissue, muscles, liver, we know it is a mitochondrial disorder. So simple. So you made a diagnosis. And how do you pick up? Do lactate and pyruvate or do GCMS to pick up the condition, and now you have molecular studies to diagnose mitochondrial disorder. So again, to diagnose mitochondrial disorder, you don't require expertise. This child came with very high lactate level and persistently it came that lactate by pyruvate ratios were high. Fine. So if you are born with healthy mitochondria, whom should give credit to? Mother or father? Mother. So if you are all fortunate, if you are born with healthy mitochondria, beautiful mitochondria, very active, we should today thank our parents, especially mother, that she has beautifully passed your mitochondria to you, so that you are having such a wonderful thing. So if the child, they are born with healthy mitochondria, which are the common thing which will damage mitochondria? Now you tell me. You have all read about free oxygen radical disease. That was your first semester only. So these free radicals, where are they coming from? Commonly, they are damaging mitochondria. So today, if you see all the articles, they'll revolve around you preventing free oxygen radical disease. So these are radicals which keep on damaging mitochondria. Mother has beautifully passed mitochondria to all of you. Because of that, you are active, you are sitting straight, you can walk, you can run and jog. A mitochondrial disorder person cannot run for a long period of time. Why? Because after some time, he gets lactic acidosis. When you run for a long time, the lactates are increased in the muscle. Already child has very high lactate, so he'll start getting cramps. He can't run for longer time. So that is a clinical clue to identify this as mitochondrial disorder. Before that, this is a diagram which shows that during fertilization, father has mitochondria in the tail of the sperm. During this fertilization, the tail is lost, so the father cannot transmit any mitochondria to the child. So the entire mitochondrial genome, what we have got, is coming from our mother only, exclusively. So you all know the body, how many genes we have got in body total? Approximate idea? Around any number, rough number, because see, even I also don't know more because there are many genes discovered. Any rough number, idea? MCQ maro na, kuch chalta hai. Hundreds, thousand or million, at least we can come to that. Around any number, guess for. So we have around 25,000 to 30,000 genes. Cell has got two parts, nucleus. So 30,000 genes are nuclear DNA. And only 37 genes are coming from mitochondrial DNA. So we have got two type of DNA. One is nucleus, which is giving 30,000 genes, which make you absolutely fit and healthy. And these 37 genes, which are there in mitochondria, are inherited from mother. So again the question is that, if you are having wonderful mitochondria, which oxygen radical things are damaging your mitochondria? Any preparations, food, environmental agent, what is your guess for it? Which is damaging mitochondria? Because if you see commonest presentation of mitochondria, it is chronic fatigue syndrome, which always, most of us are always fatigued. If you see a patient comes with chronic fatigue, you say rule out thyroidism, hypothyroidism, rule out B12 deficiency, rule out vitamin D deficiency, correct? These are again, if you see hypothyroidism, what is it? Low metabolic rate. So all this is related to mitochondria only, at the end of the day. So if you see common presentation of mitochondrial, this is chronic fatigue syndrome, migraine, most of us get migraine, ataxia, sometimes in bipolar disorders, lethargic, depression, all of them. So which are the free oxygen radical which can cause it? Any conditions, which substances you know, which causes, and how do you prevent it? Basically that is the thing. Any free radical, which are the compounds? Commonly the packet preparations, compounds with preservatives, which we get not of this, which caused most of the time mitochondrial damage. Just remember, like even my teacher has fantastic memory. They remember my classmate, my batch, second batch, 10 batch junior and 10 batch senior. Correct? They have fantastic memory, very active, and all these things. They are born with healthy mitochondria, because if you just see the retrospective analysis, the only thing which they have not had is packet food. That time no junk food available, and this processed foods were not available, which was causing a lot of radical disease. And that's why one of the conditions which cause mitochondrial epidemic now is because of these substances. And second one, lack of sunshine. The only thing what we used to do as an exercise as a school days, just remember, what was the exercise we used to do? What teacher used to make us? PT in sun. Surya Namaskar in sun. Today we are going to gym, indoor, no sunlight, all glasses everywhere, hardly an exposure to sunlight. So probably, if you see retrospectively, all our exercise elements are in the sun with sun rays, which is an excellent source of stimulation of mitochondria, that has prevented depression, that has rejuvenated mitochondria. And which kind of exercise you should do to build up your mitochondria? You need to maintain your mitochondria, all of us, including me also. So what we should do? It is called as, now we call as HIIT, high intensity intermittent training. Initially it was just Surya Namaskar with your own body weight, and do Danda Betak. So our teacher did only that, Danda Betak, Surya Namaskar in sun, in the rooftop or in the terrace. And they have got such a wonderful mitochondria. We got away from those things, and today we are taking processed food, hardly an exposure to sunlight, and we are doing only maybe brisk walking. But it is important to stimulate, stretch your muscle, rejuvenate your mitochondria, keep them healthy and keep them growing. And which is the common medication which is used for mitochondrial disorder, which we use in OPD practice? There are so many agents which we use in mitochondrial disorder. Excellent, levocarnitin, yes, very good. Anything else? Excellent, coenzyme Q, very good. Anything else? Multiple thiamine, riboflavin, B12. But if you see just hardly 5 ml or 10 ml of carnitin, can it take care of entire mitochondrial genome? Less likely. So that's why the primary thing for treatment of this disorder is not just medication. It is to stimulate the muscles, stimulate it with their exercise, regenerate mitochondria and keep them healthy. So exercise, sunshine, and then these medications are important part of mitochondrial disorder. So today we covered one simple disorder which is called as oxidative phosphorylation as mitochondrial disorder. So basically what is metabolic pathway? Like Dr. Khare sir has asked me, what is this metabolic pathway? Need to explain our students. So it is the job of a plumber. Basically what happens? A substance A gets converted to B, then to C. There is one enzyme which is triggering B to C. This enzyme is not there. What will happen? B goes to D and forms a toxic metabolite. So what is the job as a metabolic specialist? You be like a plumber. Try and decrease this block by flushing, that is use of medication, or use artificial enzyme replacement. So these are the two strategies of treatment. Now I will just cover one or two cases which are very, very interesting, very simple, which we can spot diagnosis in OPD practice. Like sir, Dr. Khare said, you try and identify one disease with one treatment. One disease, one treatment, one disease, one food supplement, that's it. If you see a child in OPD with neurodegeneration, altered pigmentation of hair, skin and eyes, born of a consanguineous marriage, with smelling urine, which is little abnormal over a period of time, and the child deteriorated at 7 to 8 months of age. What is your diagnosis? Excellent. Why 7 to 8 months of age? Very important. Like sir has also asked me, like what time they would present? A severe metabolic disorder present in NSU? A slightly slow, milder form will present late. But why 7 to 8 months of age? What goes wrong at 7 to 8 months of age? Arey, you know everything, come on, you are so talented. In fact, at our time there was hardly any exposure as digital studying also. There was hardly any digital studies when we were there to research on our own. 7 to 8 months, let us see, I'll give a clue, food. What? 6 months is exclusive breastfeeding. So 7 months what happens? Excellent, weaning, which is a common weaning food which the parents use. Dal water, rice water. Dal contains protein. So moment the child is exposed to protein, this metabolic disorder will start getting aggravated. So as always, very, very important, very $1 million question. When did the child got deteriorated? If you see propionic acidemia, classical history, feeding got over, child was introduced with dal, suddenly child deteriorated, hyperammonemia, ketosis, convulsion, admitted in NICU, shown spasticity and now rigid child. Second one, the child is on exclusive mother feeding, develops cataract at 1 year of age. Diagnosis? Excellent. Galactosemia, because slowly the lactose in the milk is getting converted to galactose and getting accumulated in the eyes. Child has taken lot of sugar in terms of fruit juice and suddenly present with hypoglycemia. Excellent. Fructose intolerance. Because if you take sugar, what will happen? Insulin will increase. Correct? In case of FDPD, the pathways, I will show a diagram when it is cut. So this child has classical history, deterioration at 7 months. But why pigmentation is affected? Because there are only two conditions in metabolic disorder when the pigmentation is very important. Can you name them? One is PKU. Second one? Excellent. Anything else? Very good. Anything else? I wanted to. Jor se bol. Excellent. Very good. Alkaptonuria. Very interesting story about alkaptonuria. I'll just take 2-3 minutes. Alkaptonuria was the first metabolic disorder which was discovered by Sir Garrod in 1908. He was a rheumatologist. He was working with cases of familiar arthritis. Few of the members in the family were affected with arthritis. So he used to collect sample of urine and blood, keep it in the laboratory, next day come and process them. Sometimes what happened on the Friday long weekend, he had put 3-4 tubes of patients with arthritis and they were left alone. And when he came back in the morning on Monday, he discovered that the color of the tube changed. What the color must have changed? Excellent, black. So that is how alkaptonuria was discovered. So the first person to describe alkaptonuria was Sir Garrod. And again, this child, I will just explain to you why the pigmentation gets triggered. This is a simple pathway. If you remember this pathway, all your two disorders will be clarified. So if you see this pathway, this is phenylalanine get converted into tyrosine. If you have block over here, phenylalanine will raise and phenylpyruvic will raise. Because of this block, now tyrosine is not going to form melanin pigment. So if you see a child with hyperphenylalemia, very high amount of phenylpyruvic acid or lactic acid or ketones, basically these are acids, correct? These are byproduct. As I shown in the diagram, this is phenylalanine is harmless product. But moment it gets converted into the harmful product, it will damage the brain. And because it is not getting converted into tyrosine, there is no melanin form. So that's why the child will have no pigmentation, eyes, hair and skin will become less pigmentation. Now let us look at alkaptonuria. Phenylalanine gets converted to tyrosine, then phenylperoxy acid, homogentic acid. This homogentic acid doesn't get converted into next product. There is a block over here. So what will happen? Reverse cycle and it will form melanin. So when this melanin gets accumulated, it will not get accumulated at 1 year of age. At around 2nd decade and 4th decade, where does it get accumulated in alkaptonuria? Excellent. Cartilage of the ear and cardiac tissue and skeletal muscle and spine. So if you see a child with pigmentation abnormality, foul smelling urine, presented at 7 to 8 months of age, abnormal posture of the body, weaning diet, given protein. So next advice, what will you give to the parents? This is again a diagram. Phenyltyrosine required for adrenaline, dopamine, melanin and thyroxine. In absence of these things, all this will be suppressed. So child will have less adrenaline, less of melanin, no pigmentation, sluggish child, slow, lethargic. So all this will be so easy to remember. So how will you treat in the OPD basis? This is classification at what levels. Hyperphenylalemia will show what clinical features. So this is a food. So for PKU, any medication is there? Nothing. You don't require medication for phenylketonuria. You require a dietary modification for optimum outcome. So when the when the food is used as a medicine, that is how you do outcome. So what is the common food you will tell them to eat? In C, whenever you get amino acid disorder, no non-veg, high amount of protein, no legumes, no dry fruits, correct? Why not diet soda? What does diet soda contain? Aspartame. This is, and that is causing hyperammonemia. So these are the food you should not take. And what should you take? Free food. So tell me the foods which has very less amount of amino acids, which should abundantly. What you can advise them on OPD basis? Fruits, very less amino acids, full of sugar. So abundant fruits, abundant vegetables which are there, and you can take them juices. So this child was strictly told them not to use protein, not to decrease the protein to almost 0.5 to 0.7 kilogram of body weight, decrease it totally, supplement them with sugar and fruits and vegetables, and they showed good outcome. So if you diagnose PKU very early in the part of the life, before pigmentation and all this abnormality, they will show excellent reversal. Right? Next one is vomiting as a presentation of metabolic disorder. What is so different in vomiting because of normal gastrointestinal and metabolic disorder? Normally, if you see gastroenteritis, vomiting, what will happen to metabolic path? Like, is it metabolic acidosis or alkalosis? Alkalosis, fine. But if you see vomiting with metabolic acidosis, rule out IM. 100% it is IM. If you see hiccups, vomiting and metabolic acidosis, 110% IM. So if you see a child coming to OPD with persistent vomiting, and he is admitted because he is very sick, you have taken the blood transfusion, or like you have taken IV line, and you found that the child has metabolic acidosis, no alkalosis, and 20 times removing all his HCl, so it has to be alkalosis, but no alkalosis, just acidosis. So vomiting is a manifestation of underlying acidosis because of metabolic disorder. So this was a child who was referred to us again with multiple episodes of vomiting. He had went for all the tests, scopy and everything, and then finally amino acidogram was done and he was picked up as a metabolic disorder. Now next presentation, recurrent pneumonia. This is very classical history. If you see neurological case, you will see that the child was पहले एक बार ना गाँव में एडमिट किया था, निमोनिया हुआ था, 2-3 महीना अच्छा फिर से निमोनिया हो गया, पहला बच्चा भी निमोनिया से गुजर गया. So they won't understand that it is not pneumonia, it is a respiratory distress. Sorry, it is just a tachypnea without respiratory distress. So this is one of the common presentation of metabolic disorder because the child are acidotic, they are lactic acidemia, ketoacidosis, they are breathing fast, and they are always labeled as a pneumonia, but actually there is no underlying lung problem. So previous child died of pneumonia, this child suffered 3 times pneumonia. They come to say that pneumonia hota hai, बार-बार pneumonia से expire होता है बच्चा. So one thing is to remember that identify metabolic acidosis in child. If you get a child with recurrent pneumonias, of course without parenchymal involvement, look at IM as one possibility. Now it is Now let us look at these two things. Ammonia level. What is the precaution you take when you collect ammonia in a child? Is it arterial or venous? First question. Arterial. But if the child most of the time thrombocytopenic, septic, so can you take venous? Okay, you collected arterial. How do you store it and how do you transport it? Ice pack. Very good. Why do you take ice pack? What happens if you don't take it? Then what happens? RBCs will get destroyed. Nah? What will happen next? It will increase or decrease ammonia level? Increase, yes. Why it will increase? Now tell me. Because of metabolism and because of the constant accretion of RBCs. So always remember that you send the sample and it should be processed within 1 to 2 hours. These are the ranges for ammonia at various levels. Sometimes in NS you would get child with 150, 180, not very high. So this is transient hyperammonia, what not significant. But if you get 1000 of ammonia, which is a likely disease? Excellent, urea cycle disorder. If you get 1000 of ammonia, look at urea cycle. If you get 2 to 300 ammonia with acidosis, look at organic acidemia. Fine. And if you get mild hyperammonemia, only thing is restriction of protein and modification of diet. So remember the range. 1000 of ammonia, if you see a report with 1000 of ammonia with no acidosis and anything, you are hitting on urea cycle. Because I said, only ammonia is raised, commonly is urea cycle disorder or hepatic dysfunction. If the child had suffered from hepatic dysfunction, will get very high ammonia. This is another simple pathway. Like now it is 8 o'clock. You must have had your food at around 3 o'clock, correct? So first 2 hours of your postprandial session, which is very active part of your day, which product was used by the body to maintain your energy level? See, we eat carbohydrate, protein and fat to generate ATP. Remember that everything is सब नदियाँ समुद्र में जाके मिलती है, समुद्र ATP है बस. ATP is important. Whatever you eat, final generation is ATP. If you eat less food, you will generate less ATP. If you eat more food and less exercise, you will generate more fat and you can accumulate more fat. So first 2 hours of your lunch, which part of food is used for your metabolism and ATP generation? Carbohydrate, excellent. Later after 2 to 6 hours, now it is almost 6 hours. We are all feeling hungry, lethargic, AC is there finally, but looking for coffee, tea, biscuits. Now which will be used? Next substances from the body will release. पहले कार्बोहाइड्रेट इज अ फर्स्ट वेपन, बराबर. जो बाहुबली पिक्चर आया सबसे पहले छोटा छोटा लोग गया, घोड़ा गया, उसके बाद हाथी आता है, फिर बाहुबली आएगा पीछे से, राइट. तो पहले गया घोड़ा गया, फिर उसके बाद हाथी आएगा. हाथी इज व्हाट? हाथी इज फैट. सो your first part of your food is sugar. So that's why it is glycogen. Second one is glycogenolysis. Then next comes is fat, and last is protein. And protein will come after a prolonged fasting of 8 hours, 10 hours, because protein has to come from muscles and bone metabolism. So you have to have muscle getting damaged, then complex protein released, then amino acids are released. These amino acids will now generate energy and maintain your fuel. This is how we collect lactate. For lactate and pyruvate, what is the precaution you should take when you collect lactate? As I said, if you say lactic acidemia, very exclusively you're looking at mitochondrial oxidative phosphorylation disorder. Again, like ammonia, it has to be collected quickly and sent quickly to the lab. So what collection, what important precaution you should take when you collect lactate level? Never ask the patient to squeeze. If you're squeezing, the muscle lactate will increase and that will come into your blood report. So the child should not be struggling. Free flowing blood should not be squeezing because the lactate is spuriously high. Second, any other thing? Whenever you send sample for lactate, you never send sample for lactate. It is lactate and pyruvate, correct? And you take ratio, lactate by pyruvate. Why you take this ratio? Because ratio more than 25 to 30 is important. You may have condition when the lactate is increased, pyruvate is increased. It is just 20-25. It is not so significant. If a persistently high lactic acidemia with ratio which is high, CSF lactate high, child is drowsy, lethargic, then you are hitting in a diagnosis of mitochondrial disorder. So precaution is that free flowing blood, preferably arterial compared to venous, collect it, put it in ice, store them and send it to fast laboratory, take a ratio and calculate the ratio. Ammonia level as told you. And now, second, as I said, initial few hours of our postprandial session, we were using glucose. Now, next is fatty acid. You cannot use fatty acid directly. So, what is the product of fatty acid which you are using? Ketone bodies. Which is the part of the body which uses ketone bodies to the maximum? Maximum ketone body, which is like he is a scavenger of ketone bodies. मतलब वो खाते रहता है ketone body. जब जितना ketone body he will take it. And which is a part of the body which never uses ketone body. One which is uses maximum कौन है? Excellent, very good. So today you are active even in despite of 6 hours for my lecture, which is so boring and involved of metabolism. You should thankful to your mitochondria and secondly to your ketone bodies. We are maintaining and sustaining on this thing because it's a very boring and very tireless lecture. And which is a part of the body which never uses ketone bodies. Heart भी use करता है ना ketone bodies. Sorry. Excellent. Liver produces ketone bodies but never utilizes them. Liver. So next part, like ketone bodies are another part of the defense mechanism which are fuel. I'll give an example. In a peripheral setup you can diagnose this condition. A child comes to with recurrent hypoglycemia. During hypoglycemic times there is no ketone body formation. He has cardiomyopathy and myopathy. What is the diagnosis of this child? Hypoglycemia is there but no ketone. He is not generating ketone bodies. So there is failure of fatty acid metabolism. So which disorder you are diagnosing them? Excellent, fatty acid oxidation diagnosis. This is such a rare condition. So whenever you get a child with hypoglycemia, what you do, take a ketone, you collect urine of the child, put a ketosticks properly, see the range of ketone bodies, collect blood sample and send it to lab for estimation of ketone bodies and free fatty acid ratio. Which is a ketone body which smell like nail paint remover. Excellent, we are so brilliant and intelligent. Like, so hardly anything left for me to talk to you. Acetone is very volatile. It is like nail paint remover. So we cannot estimate acetone level in the lab. So what do? Acetoacetate and beta hydroxybutyrate. So next time you see a child with hypoglycemia with no ketone bodies formation, straight away you are hitting into fatty acid disorder. So such a rare condition, but as a second year or first, third year student, you are diagnosed it so easily and beautifully. Yes, sir. It will be present. Yes, sir. And so no ketone bodies, you have picked it so beautifully. So this was a child who is vomiting, no ketone bodies formed, and this we have picked up as again a fatty acid disorder. So now a quick review about how we used to diagnose 25 years before a metabolic disorder and how you as a young graduate, how you will diagnose as a metabolic disorder. Lot of difference. Previously, when I was a student, I was talking to sir, like we used to get a recommendation, urinary amino acid, plasma amino acid, MRST, like mental retardation screening test, and our investigation stop invariably there. So what we were doing is just identifying urinary amino acids and plasma amino acid, like PKU, alkaptonuria, very few conditions. And retardation screening test, Benedict-Rothera test for ketone bodies and sugar. Beyond that, nothing. Today we have GCMS and tandem mass spectroscopy, which is very, very important test. In 5 minutes, I will finish with that thing. Because this is very important for you to know that what is GCMS and what is tandem mass spectroscopy. Have you sent any sample for GCMS and TMS? Or you must have shared the report. Have you got the report, seen the reports now? Yeah. So which one you prefer? See, when you say newborn screening, which method is used? Excellent, tandem mass spectroscopy. And when you diagnose metabolic disorder, we use gas chromatography, mass spectroscopy. So why is so difference? In screening, using tandem mass spectroscopy and then GCMS. I'll give an example today. Today, I had to come to Sion Hospital to give a small 20 minutes presentation on metabolic disorder. Dr. Khare sir told me that we have meeting at Sion on Thursday. So, with this sentence, how much you interpret that there is one meeting at Sion Hospital at 6 o'clock. So, this is a tandem mass spectroscopy. There is definitely meeting at 6 o'clock at Sion Hospital. Next call, he will tell me that you have to report at 5:45. Your presentation is dedicated to only 20 minutes. 8 minutes will be dedicated to students to interact with you. Keep minimum slides and maximum material. We'll start our first presentation and later on followed by your presentation. So this is GCMS. You got lot of information what you have to do on that day. So TMS is a screening method which just identifies, I'll tell an example. Now see this diagram. Very, very simple and very important diagram. In phenyl PKU, you diagnose phenylalanine, but that is not diagnostic. I said in PKU, it is not elevation of phenylalanine which is damaging the child. It is conversion of phenylalanine to phenylpyruvic acid and lactic acid, which are harmful substances which are damaging the child. So if we just say phenylalanine, they would say the child has taken some food and that has caused phenylalanine raised. Doesn't give diagnosis. But today, with GCMS, if I pick up phenylalanine, phenylpyruvic acid, phenylactic acid, you are given me a concrete diagnosis. So that is. Now next see the diagram. Propionic and glutaric acid. Propionic acidemia and methylmalonic acidemia. C3. So it doesn't make any sense, na? So 3 is 3 is 3. This is basically, this is a what you call movement of the carbon atom. So C3 for two substances not palatable now. You need to know whether it is propionic acidemia or methylmalonic acid. Because in propionic acidemia, early part you give biotin. In methylmalonic acid, I give B12. So unless until you know the diagnosis, how can you start biotin and B12 together? So you require a detailed information. So in case of screening test, tandem mass spectroscopy is excellent method. And only thing which you can identify is that, see, for fatty acid disorder, this is the best method. It has given 5 to 6 substances and compound, while in amino acid and organic acid it has hardly given any information. Today what we want is information. So tandem mass spectroscopy is excellent tool for fatty acid disorder. Remember this thing. If it is a simple amino acid disorder or organic acidemia, it doesn't give much helpful role. You need to go for GCMS to pick up and get additional information. So GCMS is gas chromatography mass spectroscopy. It's a different kind of machine wherein a retention time of substance is there and lot of information you get. You get all the substances which are accumulated and excreted in the body. So metabolic package, you have lot of companies which will show GCMS and TMS as this cost. But bottom line, just to summarize my presentation for now, next 2 to 3 minutes only. If you get a child exclusive lactic acidemia, look at oxidative phosphorylation disorder or mitochondrial disorder. Hyperammonemia, exclusively look at urea cycle disorder. Exclusive ketone body abnormality, look at fatty acid disorder. And if you get like Pushpa dosa, look at organic acidemia. So many things combined together. And again, after screening test, now you feed it down. If the child has only hyperammonemia, look at urea cycle disorder only. If it is multiple factor, now you look at organic acidemia with GCMS. And it just no ketone bodies, ask for TMS, tandem mass spectroscopy. So if you just remember, it's only 15 to 20 minutes of my small lecture. It would be so easy to identify. 95% of the metabolic disorder you will identify. First clinical symptom, sleepy child, lethargic children, not getting up, no septicemia, still sleepy, sluggish developmental, periodic vomiting, respiratory distress, recurrent pneumonia, non-specific symptoms, but symptoms are almost like normal elements, but not fitting into septicemia. So if you rule out septicemia, if you rule out this condition on priority basis, look at metabolic disorder as a last option. And just to finish off with this thing, you have heard about exome sequencing, intron sequencing, correct? So which is common exome sequencing which you have heard about? What is clinical exome and what is whole exome? I'll just summarize it. Today is the last match between India and Australia, which they are going to qualify for WTC, which is going to be held in the Lords in the month of June. If I watch the entire match today, 80 overs for 5 days, 400 overs, what I am going to watch is called as whole genome studies. You watch every over till last day, 400 overs, whole genome. In this whole genome, what is problem? The operator will show me 1 over and 1 over of advertisement. The over, cricket over, is called as exome and advertisement is called as intron. You know what is the difference between exome and intron? Exome is a useful part of genetic information. Intron is almost like a dustbin waste. So I have to now remove all introns. I don't want to remember how many advertise policybazaar.com I saw, Airtel I saw, how many times had Deepika Padukone and how many times must have seen Shah Rukh Khan at that time. So I don't want to see so many things. So intron I remove. So now exome. So when I say whole exome study, it will give only the cricket part. Now I want to watch only batting of Steve Smith. Today he has made a century, na? The Australian batsman. Khwaja has just made century. So I want to want only Khwaja. So it is called as a clinical exome. So you ask the laboratory, I want to do exome studies for metabolic disorder, for organic acidemia. I am differentiating between methylmalonic acid and propanamic acid. Run the genes on that. So they will give information. So you don't know anything. So when is the clinical, like sir was telling me, a very interesting thing, that if you do genome of all of us, you will find out something which you are likely to get later on. Some metabolic disorder, some ongoing disorder, some neurological illness, which is not relevant. Today you are healthy, so identify them right now is not important. So whole genome is not so primarily popular method. What you require is only exome studies. In exome, if you know the disorder, ask for clinical exam. Suppose you see neurometabolic disorder, child has come with dystonia. You ask for all neurological exam studies for dystonia. He will do all 10 to 15 genomes which are there and give a diagnosis. So that's why in clinical practice, ask for clinical exam, narrow down your diagnosis with the help of these metabolic studies, use them judiciously, send the reports properly, analyze them properly, use basic TMS and GCMS properly, do the exam studies if it is required, and that would solve most of our problem. And to summarize, I always remember this is how my sir has trained me. When we used to present, same like what I presented to you, as a postgraduate, he used to say that people have not come here to see how much you know. They have come here to see how much they should know out of you. So today I hope I have made the same thing, that you should know how much you should know in clinical practice, and this is not the 80 slide which you should know. Thank you. Thanks a lot, sir. Thank you. Thank you, sir.
Any questions?